So we are live now. Good to go.
Good evening, everyone. In fact, namaste, everyone. On behalf of Intas Pharmaceutical, I, Dr. Mithilesh Nayak, welcome you all to this second edition of Practice-Pearls-in-Endocrinology. And to guide us, we are having with us Dr. Professor Subhankar Chaudhary, sir. He is a professor of endocrinology, Department of Endocrinology at SSKM Hospital, Kolkata. He is the editor-in-chief, Indian Journal of Endocrinology and Metabolism. He is the past president, Endocrinology Society of India, and past secretary for the Research Society for Study of Diabetes in India. He is the member of Subject Expert Committee at CDESCO, Government of India, and is the founder patron, the South Asian Federation of Endocrinology Society, and he has rich experience in terms of more than 170 publications in various national and international journals. So with this, I request Subhankar Chaudhary sir to guide us further. Over to you, sir.
Thank you very much, and warm welcome to our monthly meeting, Practice Pearls in Endocrinology, especially primarily for the practicing physician. I do hope last time you had useful knowledge or helpful knowledge to take your practice forward in terms of osteoporosis, bone health, and where endocrinologists are also intimately involved in management. Today, we look at something even more common, more important in everyday practice. That's to do with thyroid disorders. And we all know, maybe if we take the number of people with thyroid disorders in the population, in the community, it may be about 5%. Maybe if in our clinics, of course, we see much bigger numbers, but 5 to 10% would have a thyroid problem. In the past, of course, it was much more gratifying to treat patients with thyroid disorder because they usually come in a more advanced stage, severe cases of thyrotoxicosis or hypothyroidism. Nowadays, they come much earlier, and because tests are done more frequently. So if you have a severe disease, then the effect of treatment becomes much more prominent, effective, seen easily. Patients feel easily and remain gratified. Today, possibly, we are treating many patients at a relatively earlier stage of the disease, which is good for them. But in order to understand, we do not need a very big, very complicated system of investigations in most instances. We can go a whole hog for some patients, but mostly we do not need. So we can jolly well do with a simple thyroid function test, blood tests, which are now available not only the metros, but also in the district towns and so on. And maybe sometimes you need an ultrasound scan. Sometimes you need an FNAC. So today what we shall try and understand is to make more sense of the thyroid function tests that we commonly order, that we commonly advise. And of course, we have seen prescriptions advising T1, T2, T3, blood for T1, T2, T3. Of course, we don't yet test for T1, T2. We do test for T3, but we more commonly test for T4 or free T4, TSH, and so on. So we have two experts to guide us through this. So what we try and understand in the first part is to understand what is the normal physiology, what affects this thyroid function test. Is it just we can treat just by looking at those figures that anyone sends across the numbers to us, or do we need to look at the patient as a whole? So to do justice to that, we will have Dr. Sanjay Kalra, who is consultant and head of Bharati Research Institute of Diabetes and Endocrinology, and who is the current president of our very dear Endocrine Society of India, has also is the vice president of South Asian Federation of Endocrine Societies, is education editor of International Society of Endocrinology and section editor in endocrinology in the API textbook of medicine. And he is someone who can make the most complex things seem easy for you. So we'll have Dr. Sanjay Kalra, and then we'll have another maestro, Dr. Bipin Sethi from Hyderabad, and we shall formally introduce him soon after. But he will take us through actual deciphering thyroid function tests in different real-life scenarios and guiding our progress through our daily clinical practice. So over to you first, Dr. Sanjay Kalra.
Thank you, sir. Thank you for that introduction. Like you rightfully said, earlier thyroid management was quite gratifying, and we would get people in extreme stages of disease, whether hypo or hyperthyroidism, and then it would be very gratifying to treat them. Now, actually, the opposite is true. In principle, treating the thyroid should be very simple. All we need to understand is the relationship between the hypothalamus and the pituitary and the thyroid, and then the thyroid and the thyroid receptors. If we understand this hypothalamo-pituitary thyroid axis, it becomes easy to understand that T3 and T4 on one hand and TSH on the other hand have an inverse relationship. If we are able to do this, and then we have very good drugs available, both for hypo and for hyperthyroidism, it should be very easy to achieve euthyroidism. How do we define euthyroidism currently? It's defined as a normal TSH value. Of course, we have evolved, we have person-centered ranges for a normal TSH value. So in pregnancy, in preconception, the TSH value is different. For the elderly, a different TSH target may be required. For others, it's different. For somebody who has been treated for thyroid carcinoma and who is under suppression therapy with thyroxine, the TSH value is different. It is 0. It's undetectable. Let's compare this definition of euthyroidism with the definition of euglycemia. In diabetes care, we do not aim only for a normal glucose. We aim for overall well-being. We speak of pleiotropic benefits. We speak of vasculometabolic benefits. We speak of viscerometabolic health. Let's also compare our thyroid targets with the targets that we practice in overall medicine. As physicians, as responsible physicians, we aim for health. How do we define health? Health is defined as a state of not only physical, but also mental, social, and emotional well-being. Now, see the difference suddenly. The way we define euthyroidism is different. The way we define health or targets in any other disease is different. No wonder then that our patients are usually uncomfortable with us. They are dissatisfied. And like Dr. Subhankar said, now I still see cretins every now and then, maybe once or twice a year. But the kind of relief and gratitude that you would get when you would treat a person with a TSH of 150 plus, that's not there anymore because persons are coming with less values of TSH. They come in earlier. That's one challenge. The other challenge is that the persons are unhappy with us. Why is it that they're unhappy? The reason is that our definition of euthyroidism is different from their definition of health or euthyroidism. What the person with thyroid disorder wants is not only symptomatic relief and a biochemically normal value, the person also wants viscerometabolic optimization. We'll speak of this in the next few minutes. The patient wants good psychological health, including psychological well-being. This is a positive attribute, and lack of thyroid stress, lack of a negative attribute. And in certain societies in India, for example, where I work, social acceptance is also an issue. A label of hypothyroidism or Hashimoto's thyroiditis is cause enough for breakup of a marriage or for breakup of betrothal. So the moment the potential in-laws get to know that a girl is on thyroid medication, that is cause for breaking of the marriage. So all these are parts of health that the physician has to take care of. Let's talk about viscerometabolic optimization first. When we are managing thyroid, we have to look not only for the look out not only for the TSH and for symptoms, but we also have to make sure that there is no glucometabolic dysfunction. We have to make sure that cardiometabolic health is optimal. We have to look for what we call barometabolic disorders and also viscerometabolic disorders. Now, this slide is quite a mouthful, so let's make it simpler. We know that in persons with hypothyroidism, the prevalence of type 1 or type 2 diabetes is more. Also, GDM is more. So we have to be vigilant. In persons with thyroid dysfunction, even those with so-called subclinical hypothyroidism, The risk for atherosclerotic cardiovascular disease and heart failure is more. This is mediated by various factors, by endothelial toxicity, by hyperlipidemia, by hypertension, by so many factors. But we have to watch out for CVD and also for heart failure. Remember the classification of heart failure that is used in cardiology now. They do not wait for symptomatic heart failure to occur before labeling it. When you see the staging of heart failure, A, B, C, D, A and B is actually structural and functional causes which may predispose to heart failure. And hypothyroidism per se and hyperthyroidism per se enter the definition of heart failure because they predispose to this syndrome. So we have to be careful. We must also remember that when if hypothyroidism is a cause of heart failure with restricted ejection fraction, hyperthyroidism or uncontrolled graves is also a cause for heart failure with increased ejection fraction, not only preserved but increased ejection fraction. We used the word barometabolic in the previous slide. This reminds us to watch for obesity or overweight and dyslipidemia, which is very common in hypothyroid patients. And when we speak of visceral health, we have to keep in mind the liver, the kidney, and the ovaries especially. This is the biomedical aspect that we spoke about. But you remember in redefining euthyroidism in the first slide or so, we spoke of psychological and social health. And this brings us to the concept of thyrostress. If your patient is unhappy or is distressed for whatever reason, it may be related directly to thyroid, it may be related indirectly to the thyroid, it may be unrelated. Then it is the physician's responsibility to screen for stress and to manage stress. This can be done non-pharmacologically, it can be done pharmacologically, and you may have to refer to a mental health professional. But it is our duty as the frontline care provider to take care of this. Now, this is beyond numbers, what we have spoken so far, but what about numbers as well? And this song from this very old Indian Hindi movie by Geeta Dutt uh, reminds me of the status that we encounter now with thyroid function test. जाने क्या तूने कही? We do not know what the thyroid function is saying. जाने क्या मैंने सुनी? We do not understand what the thyroid function is saying to us, right? But बात कुछ बन ही गई. So usually we are able to manage. And Dr. Subhankar spoke about thyroid function tests. Sir, I work in a place where 20 years ago, 21 years ago, I completed my fellowship and came back home. And the local civil hospital gave me a TSH report of minus 2.5. So I was stunned and flabbergasted, and I was too afraid of my professor, Professor Kochupele, to go back and ask him, sir, what do I do with a TSH of minus 2.5? So I asked the local physician, what do you do? And he said, Sanjay, what do you think? I have not complained to the lab guys. So I said, then what happened? He said the laboratory person who is an MD microbiology is saying, Doctor sahab, ye USA ki machine hai. This machine comes from USA. How dare you argue with a US American made machine? If the American made machine is giving you minus 2.5, then it is minus 2.5. So that is the kind of practice that I began 20 years ago. Mercifully, things are much better. But at that time, I had to go back to clinical medicine then. And though these are not in routine use now, and these indices have not been, they have been taken out of the standard surgery and medicine textbooks, I would still like to remind all our viewers and myself as well of the symptoms and signs suggestive of hypothyroidism. A delayed ankle jerk, a sluggish ankle jerk, is perhaps the most important sign of hypothyroidism. Slow movements as well. Another sign, if the patient is walking slowly into the OPD, there can be many factors. It might be osteoarthritis of the knees, but think hypothyroid. A coarse skin. So maybe not in COVID times, otherwise take some time to touch the skin of the patient. It might be coarse, it might be cold. Look for diminished sweating. And hoarseness of voice is something you can listen to. Similarly, for hyperthyroidism, so for hypo, we have the Bilivix index. For hyperthyroidism, again, you have symptoms and signs which can tell you that the person is hyperthyroid. So beyond numbers as well, there are so many things to do. You can elicit a good history. You can look for signs. You can talk about psychosocial health. And you can also explore biomedical health beyond T3, T4, TSH. But even when we look at T3, T4, TSH, we have to be aware of the assays that are being used. So read the fine print in the lab report. What assay is being used? Is it ELISA? Then you might want to throw it in the dustbin. Is it chemiluminescence? Is it something called fluoroimmunorescence, enzyme-linked fluoroimmunorescence? That the longer the name in your lab report, the more dangerous and the more risky it is. That's something I would like to say. The shorter the name, the better it is. See the quality of the lab. And if you have a lab which is always giving you crystal clear reports, from your lab, always the T3 and T4 are low and the TSH is high. There is never a mismatch between T4 and TSH. There is never a mismatch between T3 and T4. That lab is not to be trusted. If they have not written the name of the method clearly, if they have not written the accreditation that they have got, then again, you may wish to revisit your choice of laboratory. Dr. Vipin Sethi sir will be speaking about interpretation of thyroid function tests, but I'd just like to reinforce before his talk that first you read the TSH, try to correlate with symptoms and signs. Remember, correlate with symptoms and signs. The number alone is not enough. You have to think beyond numbers. Then you read the T3, T4 value if it's there, then correlate with symptom signs. And if required, you can always order other tests. Remember to keep your mind open. Do not have a diagnosis and then do not try to fit everything into your diagnosis. Keep a mind open. Usually high TSH will be primary hypothyroidism, but it can be just because of obesity per se. You reduce the weight by 2 kg and the TBG comes down and the TSH comes down. It might be because of over-treatment with anti-thyroid drugs. So go out of the way. Maybe the patient is taking methylmercazole or carbimazole. And if the patient says, I am taking a thyroid tablet at home, it's in a bottle. You're not sure what tablet it is until you see it yourself. Subclinical hypothyroidism is important. Let me spend 1 minute on this slide. When you have subclinical hypothyroidism, you have to think beyond numbers to see whether you want to treat or not. So when will we treat a patient with subclinical hypothyroid? The numbers will not tell you. It is the symptoms, the phase of life, the obstetric and gynecological history, comorbid conditions like depression, heart failure, chronic kidney disease, and laboratory markers or antibodies, which will tell us whether we have to treat a patient or not. So here again, we have to go beyond numbers. But there are different numbers as well, which are called surrogate markers of hypothyroidism. So if you have a person with dyslipidemia, raised liver enzymes, raised creatine kinase, again, maybe these are indications for treating subclinical hypothyroid. This is because these surrogate markers may suggest something called tissue hypothyroidism. So why many of our hypothyroid patients are unhappy? And if you feel that your patients are happy with you, I would just request you, just go on social media, go on Google, go on Facebook, go on WhatsApp, and you just explore on the net what people are saying about thyroid. On Twitter, if you see, I think one of the most maligned specialties is endocrinology, and people abuse their endocrinologists and thyroidologists like anything because they are not happy, because they are not getting what they want, which is just good health. Why is that? Because we are not able to think beyond numbers. If we can think beyond numbers, if we can understand the limitation of many of our assays, the limitation of many of our numbers, we can also understand the differential diagnosis of those numbers. For example, we talked about high TSH, but now let's look at low TSH. A low TSH might mean central hypothyroidism. It might mean sick euthyroid syndrome. And also when you are treating a person for Graves' disease, there again, you might have a low T3, a low T4, and a low TSH. Now, this is part of the natural history of treatment of Graves' disease. You do not have to worry too much about it. You just change you titrate the therapy. It doesn't mean that you create a new diagnosis for the patient. Beyond numbers also means, like I said, you have to be watchful for the signs. Dr. Vipin Sethi will speak about sick euthyroid syndrome. Otherwise, we can take this during the questions and answers. And the astute physician should be able to very confidently differentiate between central hypothyroid and non-thyroidal illness. This is especially important in current times when we have COVID patients. We should be aware of the fact that COVID can be associated with subacute thyroiditis. We should also be aware of the fact that COVID survivors may have an increased risk of long-term thyroiditis and thyroid dysfunction. This is based upon data from SARS-2 survivors. So the take home is that, of course, we have to look at the numbers. We have to interpret the numbers properly, but we have to think beyond numbers. We have to think social, we have to think psychological, and even within biomedical, we have to look at the entire body in a very comprehensive manner. This will be what we call thyroid vigilance. And this will help us improve the quality of health of our patients. It will help us, it will help them be happier with us. It will help us get that gratification that we had earlier with clinical science. William Shakespeare says thank you to us. Thank you from my side. And it would be nice if we could go back to our clinics, improve the quality of our history taking, of our examination, so that our patients could also say thank you to us. That will set in process a virtuous cycle of gratitude, which will be good for everyone. Thank you.
Thank you very much, Dr. Sanjay Kalra. That was wonderful. And you took it to a different level. Beyond the physiology, you went on to psychology and sociology, psychosocial well-being of the individual, which is, of course, extremely important, especially in today's complicated times and doctor-patient relationship. So we go over to the next part of our program, having had a background to what or how to look at thyroid function test results. We go on to actual examples we would feel with Dr. Bipin Sethi, a very good friend of ours, who is an endocrinologist at the Care Hospital in Hyderabad, and he did his DM endocrinology from the prestigious PGI in Chandigarh. He has different awards to his name, including Inspiring Doctors of India Award in 2018 from the Economic Times. So he has, of course, been mentor. He has conducted different courses and has numerous publications to his credit. And overall, he is an excellent person in real life and always mixes his talks, his presentations and interactions with a lot of wit and humor. So over to Dr. Bipin Sethi.
Thank you, Shubhankarji. I will try to live up to the expectations raised by your introduction, though I don't deserve any of those. I'll try to share my screen. Give me a minute. My job has been made very easy by the professorial lecture by Sanjay. So I am left with a simple job of how to go about when we see patients. Now, we know that thyroid dysfunction is very common. Patients can present with myriad of symptoms, but the diagnosis accuracy of most clinical symptoms is modest. If you have somebody who is constipated, who gains weight, who has dry skin, who is losing hair, they're not likely to be hypothyroid most of the instances. Thyroid hormones are the most frequently ordered test because they're cheap, they're easily available, and you get a report within 24 hours. The problems arise when reports don't match the expectations or there is a surprise. Sometimes we need more than a repetition to settle this issue. Patient can present with a goiter or a dysfunction, by which I mean change in the thyroid hormones, or could have both. You could have a goiter, which is your thyroid. You could have a goiter, which is of Graves or Hashimoto's. So you could have hyperthyroidism or you could have hypothyroidism. So you could have a combination of these. But the important thing that we have to realize is, does the thyroid dysfunction exist? If so, what is its etiology and what's its natural course? Is it related to drugs? Is somebody on lithium? Is somebody on amiodarone? Does it warrant any treatment? In general, as Sanjay told, low TSH signifies that there is lesser release of the thyroid stimulating hormone from the pituitary, and higher TSH signifies the opposite. However, we tend to extrapolate things. Also, when you have a low total T4, it indicates low circulating total thyroid hormones. If a high total T4 indicates high circulating hormone. It does not mean disease, but we tend to extrapolate that with disease, that anybody who has a low TSH has thyrotoxicosis. Anybody who has got high TSH has got primary hypothyroidism. If somebody has got low total T4, probably he is hypothyroid. And if somebody has got high total T4, it is thyrotoxicosis. So this is something which we need to work upon and not extend as assumptions beyond what is a fact. We would look at 3 cases to begin with. There are many, and I would request Shubhankarji to interrupt me whenever he wants to. This is a 2 days old child. His uncle rang up saying Indian people are not good at doing anything. Please sample the child for thyroid hormones. And the child came with a TSH of 3.2. The patient came on day 6. If the mother has to be believed, she's been crying for all those 4 days because she could not get an appointment with the leading endocrinologist of the city. So she finally landed with us. We asked her to repeat the test, or for her satisfaction, not ours, and the values were normal. TSH has come down from 32 to 1.72. Just think about it and try to see what it could be. Second patient is a 15-year male who is referred for low T3, low T4 total and a normal TSH. He is not hypertensive, he has no pedal edema, he is non-diabetic for 6 years. So what could this be? Then we have these two examples. The first one, obviously, is a child who has been sampled too early. The recommendations for neonatal sampling are on day 3. And when the child is sampled on day 6, child is euthyroid. This particular individual is being treated by a diabetic center of repute. He actually does not want to talk to you about anything else, but he wants you to interpret his reports. He basically has got proteinuria because of his type 1 diabetes, which is there for the past 11 years. And this is causing his T3 and T4 to go low because the binding globulins are also being excreted in the urine. Now we look at another patient who is 66 years female. She's received radioactive iodine treatment for Graves' disease. She's coming for myalgia and fatigue. The TSH has been done. The level is 0.01. CPK levels are high. She's been referred to a neurologist because she complains of muscle pains. And she is slated for a muscle biopsy and EMG. What is this? Her T4 was subnormal, 0.2 microgram per kg per dl. We know that when somebody becomes hypothyroid after a period of thyrotoxicosis, the TSH actually takes quite some time to recover. It's the T4 which is important, and T4 was not done in this place. This patient had frank hypothyroidism, but the TSH would not have become normal. Then we have another example wherein we were called very callous. The patient has received radioactive iodine treatment, is on replacement therapy for hypothyroidism according to the patient, among other things like calcium supplements and vitamin D. The physician asked for TSH, which was 0.01. She was referred to an endocrinologist, and the endocrinologist left the dose unchanged. Now, the patient's physician rang up to the endocrinologist, which happens to be me, saying that, were you sleeping when you saw this patient? This patient's TSH is 0.01 and you would have not changed the dosage. Can you think of a situation when this decision is right? This patient had carcinoma thyroid papillary, which has been excised. The tumor was 4 centimeters. She has inadequate response. Her thyroglobulins are 200. Antithyroglobulin antibodies are negative. So she requires more than the normal suppression. And this was actually normal for her. So we had to talk to the physician and tell him that this is actually relevant. Now, patients always blame the labs, and Dr. Kalra just told you how you can suspect the labs. But this patient had been checking his TSH levels very frequently, every 2 weeks. And first level was 0.01, second is 0.07, third is 6.07. Fourth is 19.7, and finally it is 0.7. I don't know why he got this test done, but he says that all the reports are wrong. But in this process, can you think who is wrong? This patient had subclinical thyrotoxicosis due to subacute thyroiditis. And as things happen, first there is leakage of the hormone, the TSH comes down, then the T4 becomes normal, then it goes below normal, and then it becomes completely normalized in 80% of the cases. This is what exactly happened to this patient. Patient went through a phase of transient hypothyroidism, and this is the very reason why if somebody has got borderline TSH, you are mandated to repeat that within about 6 to 12 weeks so that you do not pick up subclinical hypothyroidism and start wrongly treating, except in pregnancy or infertility when somebody is planning pregnancy. So this patient was not, the lab was not wrong, the person who was interpreting was wrong. Now, this is a person who had been diagnosed hypothyroid in the postpartum period. Her TSH was 100 and she was more than 100, and she was treated and normalized her TSH. She came for advice during second pregnancy 3 years later, and her TSH was 1. So what would you tell her? You would tell her that you require to increase the dosage during pregnancy, etc., etc. But she says, I never took any drugs for 2 years. And she believes that Baba Ramdev has cured her thyroid. So one needs to know that specifically in the setting of postpartum hypothyroidism, there is a possibility of 30 to 50% of women becoming euthyroid without having to require treatment. So before you jump to start scolding the patient, you should know this possibility. And also, if a person who has been diagnosed hypothyroid in the postpartum period wants some revision in treatment, wants to consider stopping treatment, you should always give that patient a chance. This patient is hypothyroid. On workup, the TSH is normal, but she has persistently high antithyroid antibodies, and her colleagues have told her that you should try to get rid of these antibodies, to try steroids, the cyclophosphamide or plasmapheresis, and what the Google Ma says, and she wants to put an end to this. What would you like to do? And what are your concerns? Well, you would not like to treat this because there is no point treating. This is just an indicator of the autoimmune process. And by changing the titers, you are not going to make any difference. So never ask the patient to get antithyroid antibodies done, except in situations which Sanjay just mentioned, that somebody is having subclinical hypothyroidism. You want to know whether the patient requires treatment or not. Then you can do it. Otherwise, don't do it. And our concerns are that there is a slightly higher risk of abnormal pregnancy outcomes in terms of pregnancy losses in patients who have this, and this cannot be modified by treating antithyroid antibodies. This patient is admitted in ICU for pneumonia. Now, this was before COVID, so please don't jump into COVID, though it could also be in the COVID era, as Sanjay remarked. The T3 is 0.39, T4 is 3.4, and TSH is 0.09. Patient is referred for secondary hypothyroidism by a very alert internist. Now, what test would you do to confirm sort of that this is not the case? This is a patient who is having sick dual thyroid syndrome, or which is known by some different names. The tests that you can do in this postmenopausal woman are FSH. If FSH is low, then this is secondary hypothyroidism. If cortisol is low in the time of stress, that in time of stress, ACTH levels are high, and cortisol typically is more than 20. And if it is not so, then you might think of secondary hypothyroidism, but it is just subclinical hypothyroidism. There are some evidences that treatment might help in these people, but by and large, the results are not very encouraging, and one need not treat this condition and just follow it up. Also, do not do thyroid function tests in a person unless there is an emergency, not emergency that somebody is pressing you to increase the revenue of the hospital. that you feel that the patient is hypothyroid, otherwise don't do it. This patient is 34 years, is stable on a dose which you have given her earlier, 88 micrograms. She's undergoing IVF stimulation cycle. On day 7, her TSH is 3.56, and the gynecologist tells her if it is more than 2.5, your baby is not going to fall, and or whatever and whatever. So what is the problem here? She was okay. She went to the cycle, and when that time the TSH was just 1.5. The problem here is that the ovulation induction increases the estrogen levels, which increases the binding proteins, and therefore, people who have got autoimmune disease, who are hypothyroid, their TSH levels are bound to go up. She need not increase the dose. In fact, the issue can be prevented by talking to the IVF people not to do a TSH level in the first 2 or 3 weeks after the ovulation induction, so that let these changes abate, and then you will get a correct picture. Now we have this health freak and beauty conscious. You men also can be beauty conscious. Look at Sanjay ji, look at Shubhankar, don't look at me. This person has been to a skin clinic. They asked him to do thyroid function test. The TSH is 0.01. FT4 is also high. He has no abnormality on clinical findings. No weight loss, no tremors, no tachycardia, no vomit. You decide not to do anything, and he comes back with more or less same values and no symptoms. He has no health issues. What is going on? You look at his medications and you find that he is on biotin. Biotin, in essays done by certain platforms with streptavidin, can interfere with and produce results similar to thyrotoxicosis. Unless you know this, you will unnecessarily treating this patient or investigating this patient by thyroid scan or giving him drugs which might produce, not always, at least a skin rash or a glandocytosis and worse still hepatotoxicity. This woman is on treatment with thyroxine 112 micrograms per day. She goes to United States, and who doesn't, except in these times, and is found to have low TSH. She was advised to taper the dose of thyroxine, and eventually it was stopped because TSH remained suppressed. She came to India for her cousin's marriage, and she got stuck. And she visits for the concerns of 9 kilograms weight gain and soreness. You look at her and you tell her, Mary, the name has been changed. You are the one who had pituitary surgery in Vellore, right? You had secondary hypothyroidism, right? And you were started on treatment because your TSH was low. So why did you go through this? Why did you have to monitor by doing TSH? You could have done a T4 or a free T4. She was started on levothyroxine because that was what she was required to do. So secondary hypothyroidism, you cannot monitor and must not monitor by TSH. You should monitor by total T4. Time is over?
No, I mean, we could go on all night, I know, but maybe because we can have some questions, but no. So would you like to go to
yes. So,
towards the end? Yeah, okay, yeah, good. If you wind up.
The TSH, which is altered, it could be that your diagnosis was wrong, person hasn't taken the tablets properly, is not, there could be issues of absorption, somebody on anti-tubercular drugs or anti-epileptic drugs, somebody becomes pregnant, somebody starts using oral contraceptives, you can have problems. There could be issues with biotin. So of the various tests that we have, only few measure thyroid function. Sensitive TSHs give reasonable idea about thyroid status. And when it is not useful, sometimes you have to use clinical sense rather than estimating free thyroid hormones. Pregnancy hospitalized patients continue to pose diagnostic challenges. One has to take proper drug history. Just if a patient has got TSH of 5.4, before you start thinking he's subclinical hypothyroidism, he wants to know, shall I continue this medicine, which was thyroxine or omeprazole? After the diagnosis is made, it's worthwhile to begin with etiology. Thank you very much for your patient sharing.
Thank you, Dr. Pipin Sethi. I know you could have gone on and on you've got, with your vast experience, all the varied conditions which sometimes make us take wrong decisions. And it was extremely illustrative looking at different conditions. I would just like to take on from your last patient who had a suppressed TSH, persistently suppressed, and you brilliantly showed that it could well be because of secondary hypothyroidism. Now, we had a similar sort of problem, not exactly the same, with a young lady who had subclinical hypothyroidism, who started on thyroxine. And then when she came to us, she had suppressed TSH. And then we said we reduced the dose and went on reducing. And we did check the earlier reports. Initially, TSH was 6.7 or 7.5, something like that. But TSH remained suppressed. And then we were in a quandary. And she had relatively mild thyrotoxic symptoms. And we asked her, I hope you've stopped the thyroxine. And she said, of course, yes, I've stopped for so many months. So even after stopping, the TSH was suppressed. So eventually, what we did, I haven't yet picked up a case of stuma ovarii. So I thought, and the T3, T4 were high, the TSH was suppressed. So maybe this is the first case that I will see of stuma ovarii or something like that. And so we did a radioactive iodine scan, whole body scan. And it did show something there in the pelvis, exactly what you cannot say, but there may be something in the pelvis on the left side. So we were quite excited. So got her admitted, and but still we were suspicious that maybe she's not giving us the entire history. So we said we have to do some other scans. We have to do an ultrasound scan and so on. So we sent her off to the ultrasound scan, and we unethically searched her room, searched her bag, and found some small packets. And then we opened the packets. They had 75 or so tablets with the mark of A on it, which eventually turned out to be tablets of thyroxine, which she was surreptitiously taking. And next morning, again, we checked, and there at least 10 or 15 of those tablets were gone. And she had eventually, we came to understand she had some psychological problems in family and all that. And so this was a sort of work of detective that we had to do, and also did unethical things. And we had great difficulty in publishing BMJ case reports. They said, who gave you the authority to search the patient's bag, and so on and so forth. But anyway, so that's a small anecdote I wanted to share. So excellent talks from both of you. We have, as usual, an interested audience, a whole lot of questions. Maybe the first one goes to Dr. Sanjay. You talked about obesity and hypothyroidism, and that's a common issue. I mean, people would quite often refer their friends, you check your thyroid because you are obese. And what do you advise? And they would be disappointed many a time because the thyroid comes out to be normal, then go to a second lab to get another test and it still comes out to normal. So what's this association of obesity with hypothyroidism?
The association is certainly there. As the body mass index goes up, TSH also goes up. This does not mean that the TSH is abnormal. It is just on the higher range of normal. And the reason is that there is an alteration in TBG, thyroid binding globulin. What we do see in practice, sir, because the social media so strongly says that obesity has to be due to some cause. No one is willing to believe that the obesity is due to exogenous causes. For example, eating too much or exercising too little. So people want a label. And two very common labels are, one is thyroid and the other one is PCOS, polycystic ovary syndrome. So the faintest of hints that I have a thyroid, maybe 5.01 is a TSH, that is enough for the lady to say, or for the girl to say, that my obesity is the fault of my thyroid, and now I don't need to exercise. The other issue is that when they come to us in practice, to the physician, they feel that thyroxine is going to act as a like a panacea, or like a magic wand. And when that doesn't happen, when you make the patient euthyroid and the weight doesn't come down, then again they feel upset. What I do in my practice, sir, is number one, all the patients with a TSH of 5, 6, 7, 8 who are obese, the T3, T4, and TSH all will be slightly on the upper side of normal. That's not classic thyroid hormone resistance, but it is a subclinical kind of a thyroid hormone resistance. What we tell them is, so what I tell them is that, yes, you do have thyroid. So I agree with them in the first sentence. Yes, you do have thyroid. However, I think we can work hard to make this a temporary thyroid. So this is my clinical practice. If I were to put you on a thyrotropic medication, then you will get permanent thyroid for life. However, why don't we work together for the next 6 weeks? Let's diet, let's exercise, let's see all the changes we can make in our lifestyle. And if you cooperate with me, I am very sure that your thyroid will be temporary, it will be transient, it will disappear. Now, what is the advantage of this counseling style? It is that I have agreed with the patient. The patient came saying that she had a thyroid label. I have agreed with her. Otherwise, if I say you don't have thyroid, go back home. The first thing the girl will do when she goes back home, she will say the doctor was had low IQ. Even I know, I am a non-medico. I know that I have thyroid, but the endocrinologist doesn't know. Second is she'll get a scolding from her husband or from her father that you wasted 5,000 rupees or 500 rupees of mine getting the test done. You actually had no disease. So that is a lose-lose situation for everybody. Once we've got agreement, then we focus on diet and exercise. And after 45 days, always the TSH comes to normal because that relationship with the BMI is there. So this is the process that I follow, sir, in the OPD.
Absolutely. Great. Smart way of doing things. Dr. Bipin Sethi, you talked about the IVF situation. So we have a question from Dr. Anurag Jain. In early pregnancy on progesterone treatment, does it impact thyroid function in pregnancy? Yeah, progesterone. Many women are on progesterone in early pregnancy, probably had a loss of pregnancy early on in previous pregnancy.
Make the difference, not the progesterone. I did not show that case that you do get a physiological decrease in HCG levels, TSH levels due to HCG, and that does not require any treatment. But progesterone in and by itself does not interfere with the TSH. We have a small joke about what Sanjay said. It in a different manner altogether, that most obese people do not have any reason. Patients with hypothyroidism have got a valid and acceptable reason for their obesity.
Yeah. If you stay with you, Dr. Bipin, Dr. Pranabandhu Shetty likes you to solve the mystery of raised T3, maybe I would assume raised T4 as well, with a normal TSH. What should we think of?
Well, if the person has got raised T4, it's most often on account of increase in the binding proteins, most often seen in the setting of pregnancy, oral contraceptive use, as also women, and genetic causes. Since T4 is more bound, we usually get more abnormalities in that. T3 also can be there in dysalbuminemia, but if the TSH is normal, then one need not worry. It could very rarely be very early stage of T3 toxicosis when the patient has to be followed up. Otherwise, raised T3, raised T4, TSH being normal consistently does not indicate an inherent thyroid disease.
Right. And for Dr. Sanjay, a person on routine check, and these days thyroid function tests are also done fairly routinely, especially also in the preoperative checkup. We used to do glucose test. Now thyroid is also part of the routine checkup in preoperative situations. So you find that T4 is maybe 5.5, TSH is 34. The patient otherwise is asymptomatic. So what should we do?
Then we should treat. If you have a patient with clinical hypothyroidism, which is defined as a low T4 and a high TSH, then this is quite clear. It should be treated. There may or may not be symptoms. Like you said, the patient is asymptomatic. And let's say the patient is not willing to get treatment. Then you can, if you are able to convince the patient, tell him that let's give you a therapeutic trial. We'll give you this drug for around 6 weeks. We'll check the TSH again after 6 weeks and things will become clear. And usually the patient does come back with an anabolic effect. So if you tell the patient what to expect within 1 week, a sense of well-being, weight loss of maybe 1 kg because of diuresis. You have to tell the patient that there'll be diuresis. Mental health, social health, physical health. If you can put that the endpoints into perspective for the patient, and these endpoints come in within a week actually, then the patient will continue with therapy. Suppose the patient is not willing to take treatment for whatever reason, then depending upon the clinical situation, and Dr. Sethi sir has described them actually very easily, very aptly. In some cases, you may want to get antibodies done. In other cases, you may want a free T3, free T4 TSH. Also, before rushing to treat the thyroid, look for renal function and hepatic function. Ask for a history of oral contraceptive use. Of course, not the numbers that you are saying, but the T4 may be on the higher side and TSH may be also on the higher side for a woman who is on oral contraceptives. So take these histories and do these evaluations before rushing to treat. But if it is clinical hypothyroid, don't feel afraid. Go ahead and treat. Make sure that you and your patient are on the same side of the table and the numbers are on the other side. So we have to treat the numbers, we have to improve them. Also, the stuff that we talked of beyond numbers, put that in perspective for the patient. Identify the targets. Once your patient achieves them, your patient will trust you more. She will not have to wait for 6 weeks to trust you because the TSH is not going to come down before that.
Another situation that we sometimes come across is patients saying, can I try homeopathy? Can I try yoga?
Yeah.
With this same patient maybe. So,
Yeah.
doctor, this will be lifelong treatment, but I want to try yoga. So what is your practical way of dealing with that? Because
So
you
what
make
I
a lot
say
of
is
sense.
yoga. Yeah. For yoga, I say, yes, go ahead. It is a healthy lifestyle. Please continue. Right. For homeopathy, what I say in my OPD is I ask them if the homeopath can swear keeping his hand on the Bible or the Holy Quran or the Bhagavad Gita, that his science knows how to measure TSH, then he has a right to treat it. But if the science cannot measure it, let us say for the past 300 years, or other alternative medicines, sciences for the past 5,000 years, they've not been able to measure TSH. They've not been able to see the coronavirus. How can they treat hypothyroidism? How can they give a treatment for management of coronavirus? So that's what we say in the OPD. If it's a school teacher, I'll say, okay, madam, you teach English, but you teach your children in English and you take the examination in English. Right? It's not that you teach your children Hindi and then you take the examination in Bengali. So then the patients understand and they take it. We try to remain less argumentative. And if the patient, of course, is in preconception or conception or pregnancy, then there's no ifs and buts. If sometimes the patient is very argumentative, then like I tell them, let's do a therapeutic trial with thyroxine for 6 weeks. I tell them, let's do a therapeutic trial without thyroxine. I'll give you a functional food. You can take turmeric. You can take uh, uh, water is something, coriander water is something that is very popular in Haryana for the treatment of hypothyroidism. So you can take that, but we will repeat the TSH after 4 weeks. If it does not come down, then we'll start treatment.
Yeah, Bipin, how do you deal with that?
Well, we tell people a little bit more, not bluntly, but more firmly. We tell them that we are not rude, but we are firm. Two of the homeopathy doctors who are leading physicians in this are our patients. And therefore, if they had treatment, then why would they come to us? For Ayurveda, we tell them that if Baba Ramdev had some success, he could have treated his eye and the graying of hair, which he could not. So there are some conditions
So,
that can be
Yeah.
treated, others cannot be treated.
We also use exactly the same.
Coming to, for example, some of these patients come for surgery, and I want to tell this audience that coronary bypass surgery can be done with a TSH of 35. It is not necessary the patient to make the patient euthyroid because his angina will get precipitated, and there is more morbidity and mortality in trying to make the patient euthyroid. The TSH is high in good centers for CABG. Please go ahead for CABG, and for revascularization, do not have to wait for normalization. If your TSH is 10 and somebody wants to undergo a surgery for carcinoma breast or carcinoma uterus, don't stop the surgery for that.
right. So on the issue of cardiac involvement, so we have a question from Dr. Sujata Devi. So there's a patient with dilated cardiomyopathy with low ejection fraction of 25%. low blood pressure, 90 millimeters systolic, with a TSH of 10, normal free T4, should we treat?
No.
And then,
What is the benefit of treating this patient? You can repeat it. I hope that this is just one value, and the age of the patient is what?
Age is not provided. Probably it's about, it's it's 35 or so.
If it is 35 years old, you can first reconfirm it and then treat the other conditions. Treating thyroid problem in this patient is not going to make any difference in this person's morbidity or mortality. There's enough evidence for that. But if your second level comes as 13 or 14, you may treat that patient.
Right. Okay. So can we quickly, maybe Dr. Bipin Sethi, can you tell us the indications for treatment of subclinical hypothyroidism? When should we treat?
Pregnancy, somebody planning pregnancy, and somebody, rest of the things are very soft indicator. There are no firm indicator. And even here, some authors think that even these are probably highly hyped conditions, because if a patient TSH is 2.6, the gynecologist, with due respect to them, whoever they may be, they say that the people have lost pregnancy because the TSH was 2.6, which is never the case. So barring these two situations, if somebody has got persistent elevation, TSH is rising, somebody is having positive antibodies, somebody is type 1 diabetic, somebody is being treated for Graves' disease with medication or radioactive iodine, somebody has dyslipidemia, then these are softer indications. Also, the last indication is symptom. Now, this is a very crude indication because everybody will have some symptoms or the other. You treat, and the patient's symptoms improve, continue, but reevaluate treatment after 3 months. If the patient levels are normal and he still complains of the aches, pains, constipation, hair loss, then I think there's no point, you can discontinue.
Yes, so it's, once again, I think it's a discussion and being on the same side as the patient and taking things forward.
Over treatment, atrial fibrillation, osteoporosis, by just chasing a number, you are going to make a iatrogenic condition, make a lifelong kind of a commitment, and cause more harm. Many people have got suppressed TSH on treatment.
Yes. Sir, I think we should reinforce this fact, what Dr. Sethi has said. You look at the patient as a whole and don't look only at the number. There are other things also to look at when you're managing the patient. So I think this should be reinforced.
Absolutely. And now we have an interesting question by Dr. Sanjay. It's a 20-year-old lady who had subclinical hypothyroidism with positive TPO antibody, started on a small dose of thyroxine from 25 to 50 micrograms. And then eventually she became thyrotoxic. TSH was suppressed like my patient, but despite stopping thyroxine, she remained thyrotoxic. Her TSH receptor antibody was positive. And then she was treated with methimazole and eventually had antithyroid drug. So her question is, was the thyroxine treatment, was it wrong? And did it cause change from hypothyroidism to a hyperthyroid state, the thyroxine treatment itself?
Patients do come and argue with us about this, and this is not a rare condition. You will see it in practice, and the longer you have been in practice, you will see more of these patients. Let's say you are working in a large hospital where there are multiple people handling the OPD. Most of the contact with the patient is cross-sectional. But when you're in practice, whether it's Dr. Sethi or Dr. Subhankar or you, then it's a longitudinal follow-up that you do for the patient, and patients will come and complain about the previous doctor. What we tell them is that thyroid dysfunction and thyroid autoimmunity is a very wide spectrum. You can move from one end of the spectrum to another end of the spectrum. This is known in thyroiditis, in subacute thyroiditis, in postpartum thyroiditis. The term that you can use is hashitoxicosis. If you have a patient who is very educated and net savvy, then you give them a term and then they are happy with that. And you tell them whatever drug was given at that particular time was given correctly. If at all any change had to be done, it was not in the choice of drug. It would have been in the choice of dose. The choice of dose is defined by the numbers by TSH. So what we'll do in the future is we will monitor you more frequently so that we are able to change the doses more frequently. Patients are happy with this explanation. Try to avoid criticizing the previous doctor. Try to avoid saying that the diagnosis was totally wrong. Though, of course, where I practice, there are many non-allopathic doctors who call themselves thyroid specialists. So even if it's Graves' disease, still they will get thyroxine. So we do get patients who are being treated with thyroxine for clear-cut Graves' disease. That's a separate matter. But this is what you say, and you just follow up the patient. Again, remember the word thyroiditis. It means inflammation. It means swelling of the thyroid gland. Sir, one other analogy that we use to explain subacute thyroiditis to our patients, and again, where I work, we don't have access to scans. So it is a clinical diagnosis only, and it's a longitudinal diagnosis. We base our diagnosis on ESR and CRP. We tell them that your thyroid gland is a small gland. It's maybe the size of a lemon. So you imagine that you've cut a lemon in slices. When there is itis, it's like the wall of the thyroid gland gets damaged. So all the lemon juice goes out. Similarly, all the thyroid hormones go out. So you will have high T3, T4 at that time. But we will try to bring that thyroid gland back to normal. We will try to bring the wall back to normal. But if all the hormones have already escaped, there's not going to be much left inside that wall. Even when we stabilize the wall of the lemon or the thyroid gland, you will have a shortage of hormones, and that may manifest today, tomorrow, or day after. And then we may have to supplement later on. So if you're able to diagnose the disease and you're able to give an idea of the expected natural history of the disease and also the expected course with your treatment, and then the clinical outcomes that you are expecting, the good ones and the bad ones, then the patient sticks to you.
Yeah.
View the patient in longitudinal manner, not in a cross-sectional manner.
Sure. We have a question from Dr. Sheetal Chandrahas Borke. I think the answer has been provided by Dr. Shetty. This is in the first trimester of pregnancy, asymptomatic patient, T3 and T4 are normal, TSH is low. Do we start antithyroid drugs? The answer is clearly no. You do expect to have a low TSH in the first trimester because HCG level goes up. HCG has an action like TSH. So sort of if T3, T4 may be slightly increased, and as a response, the TSH goes down. So I think you should repeat maybe another 8 weeks or thereabouts. Would Dr. Shetty do the same?
Yeah, we can repeat. If the patient has, in this situation, you said T3, T4 are normal, which is usually not the case.
Yeah.
If the patient has got tachycardia more than 100, has got goiter, and look for a bruit. At that point of time, bruit is important. If there is a thyroid bruit, not a venous hum, then it could be Graves' disease. But as Dr. Shubhankar said, it is most likely a physiological change. There could be hyperemesis. If the patient has lost weight, you are even more concerned. The patient could have tachycardia because of hyperemesis also. So you have to be careful. You can repeat it after 4 weeks.
Right. And Dr. Mahesh Pandya would like to know on amiodarone, patient on amiodarone with raised TSH, asymptomatic, what should we do?
Well, it depends on the duration. In the first 3 months of amiodarone treatment, the levels can go up to 20. So if somebody is having it beyond 3 months and the TSH level is high, then this person should be treated with thyroxine. This is quite unlike the autoimmune thyroiditis, the amiodarone-induced thyroiditis type 2, wherein the disease is thyroiditis and the results, you can continue treatment. Here also you continue treatment or you check with the cardiologist, but give treatment if the level is more than 20 after 3 months.
Right. I think we continue to have more questions coming in, but I think the final one would be which is the gold standard test, T3, T4, or TSH by Dr. Devendra Kumar Singh, maybe Dr. Sanjay.
For the vast majority of your patients, it would be a TSH. This is if we are thinking about the diagnosis and the monitoring of hypothyroidism. If it's somebody with Graves' disease, then you need a T4 and TSH together. Alone, I think no single drug will suffice. And there will be some cases. We spoke of central hypothyroidism. We spoke of sick youth thyroid syndrome. These are cases where you will need all these drugs, or all these investigations. And there will be a few select indications where you are confused. People with renal dysfunction, hepatic dysfunction, people on oral contraceptives, on exogenous androgen therapy. These are the four simple ones to remember. The difficult ones, you may add porphyria and various other medical conditions. Here you will need a free T3, free T4, TSH.
Right. Yeah. So I think we have had a good and, of course, a quick recap of how thyroid functions across life in different physiological conditions as one ages and in different pathological conditions. And in order to diagnose it correctly, we need, of course, the help of tests, and we need to know to get the test done from right sort of laboratory, reliable place to do the test with. But we also do remember that we need to take the tests along with the patient and see how it matches, whether it matches. Again, if it does not match, it does not always mean the lab is wrong. So we do not badmouth the lab straight away. There may be conditions which we have not picked up immediately. So we need to think about it. Sometimes in those situations, especially, we need to take the help of the endocrinologist colleagues. And very importantly, that I think both the speakers stressed on, especially Dr. Sanjay Kalra, following up a patient is also part of your problem-solving maneuver. See what happens in maybe 6 weeks or 8 weeks or even 3 or 4 months. And it's always very important to discuss with the patient frankly, and also try and not antagonize the patient as far as possible, but at the same time keeping your firm sort of approach as to what should be done. So with these, I would like to thank both the speakers for their wonderful presentation and very lucid explanation and practical tips as to what to do. There's so many different case scenarios that Dr. Bipin Sethi actually would have entertained us, kept us entertained all through the night, but we had to stop somewhere. And I know there are attendees who wanted more of them. So I'm sure they will be able to contact Dr. Bipin Sethi and learn more from him as we continue to learn. And with these few words, I would like to thank all our attendees. I think there are numbers put before me, 1,600 and more, almost 2,000 doctors have tuned in primarily to listen to you, to learn from you. Dr. Sanjay Kalra, Dr. Bipin Sethi, thank you very much. And over now to the organizers.
Thank you, Dr. Shubhankar. My name is Amit Arora, and I work as a Vice President for Intas Pharmaceuticals. As they say, all good things come to an end. So, such a wonderful session today, such a wonderful and interesting topics, great faculty, and the most important, the delegates and the people who have attended the program, which makes the things successful. And I offer the vote of thanks, and I must thank Professor Shubhankar Chaudhary for making this program and guiding us through this practice pearls in endocrinology. I must thank Dr. Sanjay Kalra and Dr. Bipin Sethi for such lucid talk today and wonderful lectures. I was listening throughout, and it was so entertaining and interesting to know about thyroid and everything about thyroid. And I must thank all the delegates and the entire team of Intas who put in a lot of hard work to bring in so many delegates. I am sure the people and the delegates who have tuned in today would have learned a lot of things from these eminent endocrinologists of this country. I would like to make an announcement. The third Saturday of every month is booked for Practice Pearls in Endocrinology, and we already have a topic from Professor Shubhankar Chaudhary, that is hormones and hypertension. I am sure you are all going to be interested in that, and please tune in on 15th of August. That is also happens to be the Independence Day, and please make a note in your diaries and be with us on that particular day. So thank you very much, one and all, once again, and we say goodbye to all of you. Have a safe, be safe, and stay safe and stay healthy. in this time of COVID. Thank you very much once again.
Thank you very
Good
much.
night.
Very good night.
Thank you.
Goodbye.
Good night.
Good night.
Thank you, sir. Thank you very
Bye.
much. So it was wonderful, sir. मुझे तो आवाज नहीं आ रही तुम्हारी. हेलो.
अभी आई ना? हेलो.
हाँ अभी आई, अभी आई, अभी आई.
हाँ. अरे ये लाइव तो नहीं है भाई? हेलो.
Sir, 1 minute.